Hi, everybody. Welcome, welcome. We're so excited that you're here joining us for the Stigma panel. Why is BPD so stigmatized? Changing the narrative. My name is Sarah Rosenberg, and I'll be moderating the panel as a volunteer for Emotions Matter. While I'm doing the introductions, we invite you to write in the chat where you're joining us from today. So I'm from Brooklyn, New York, and I'm going to be sharing some slides while you guys can introduce yourself in the chat. Okay, so Matter. Emotions Matter is a 501c3 nonprofit organization founded in 2015 to support, educate, and advocate for those impacted by borderline personality disorder. Our vision is to create a world in which every person with BPD has access to treatment and resources to achieve a meaningful recovery. You see our website down below. It's www.emotionsmatterbpd.org. Feel free to check us out, see our resources, and connect with us. Our philosophy: Emotions Matter strives to create a safe, judgment-free space for people with borderline personality disorder. We accept that there is a spectrum of experiences within the BPD community. We honor where people are on the journey without judgment or assumptions. We encourage people to define their own path towards recovery. We speak as experts of our own lived experience, not as medical experts. We have some guidelines for community engagement. Make sure you use respectful language in the session chat. Any inappropriate messaging, including harassment, bullying, or monopolizing the chat, will be deleted. We accept difference and promote acceptance, especially with regard to gender, identity, race, ethnicity, age, religion, disability, or politics. Avoid explicit expressions of self-harm or trauma, which may be upsetting to others. Panels and plenary sessions will be recorded at the conference. No screenshots or recording on personal devices. The last one is important. Questions during sessions, I mean, they're all important actually, but questions during sessions should be asked using the Q&A box, not the chat. The chat can be used for comments, but we will be actively monitoring the Q&A box, and we will have time for Q&A at the end. So we'll go through the questions at the end, and the panelists will give us some answers. Now, for the last slide, we have safety guidelines and disclaimers. If at any time during BPD Fest 22 you find yourself overwhelmed, struggling, or for any reason in need of support, we encourage you to reach out to your support system. Audience members may experience intense and painful emotions, feelings, memories, thoughts, and/or reactions to content shared. Participate at your own risk. You are also welcome to take a break from BPD Fest 22 at any time or withdraw from it entirely. In the event of a medical, including mental health emergency, please seek emergency care through a doctor, hospital, or emergency call number such as 911 in the United States immediately. So we have three very special panelists today, and I'm going to go ahead and introduce our first panelist, Alyssa. Alyssa G was diagnosed with BPD in 2018. Since that time, she has devoted herself to her recovery journey and to building a life worth living. In early 2021, Alyssa started an Instagram account called DBT Exchange for BPD content to build community through humor and hope. Go ahead, Alyssa.
Great. Thank you so much for having me, and I'm happy to kick us off today. A mark of disgrace associated with a particular circumstance, quality, or person is how Oxford Dictionary defines the word stigma. And for a long time, that definition conveyed how I felt about myself and about having borderline personality disorder. About 3.5 years ago, I was diagnosed with borderline personality disorder, BPD, while at a partial hospitalization program in California. My life had hit rock bottom and then went even lower than that, followed by an even further dip downwards, until I decided to travel across the country, both alone and afraid, to get help. My individual therapist at this PHP program gently walked me through each symptom of BPD, allowing me to explore whether I felt it resonated. Perhaps, maybe, a little, it's possible that I can relate to this just a bit. Those were my responses, and I wasn't having it. After leaving the session, the weight of the situation began to dawn on me, and I insisted on talking to the clinical director, Lily. My emotional intensity escalated very quickly to about a 10 out of 10. After a brief wait, there I sat across from Lily, shaking with frozen lemons in my hand. She then proceeded to grab the Diagnostic and Statistic Manual of Mental Disorders, the DSM, and go through each symptom of borderline personality disorder with me. Each time I shook my head no, she shook her head yes. While everything inside of me was saying this couldn't be, Lily was saying it is. Lily didn't coddle me or fragilize me. She didn't rob me of the opportunity that comes from having an accurate diagnosis. She gave it to me straight. I have borderline personality disorder. The truth is that I was wildly symptomatic, but was so deep in the disorder that I couldn't or didn't want to see it. As I left her office, she handed me Marsha Linehan's DBT manual and said, "This is your cure." And with that, I left her office and my journey with BPD began. A few days later, I had an appointment with the PHP psychiatrist. He seemed skeptical of my new diagnosis and said, "Ever since this new clinical director, we have had more borderline diagnoses. Now, I'm not saying they're not right. They know you better than I do, but usually people with BPD come in with brightly colored hair and tattoos, and you don't look like that at all." He then lowered his voice, looked at me straight in the eye, and said, "You know that the BPD diagnosis for a woman would be the same as being diagnosed as a psychopath for a man?" Was he right? Was I a psychopath? What does that mean anyway? What does this diagnosis say about me? What am I capable of? I began telling friends of my diagnosis. There was the friend that kept confusing it with bipolar disorder. You know, that one person that you have to tell like 5 times that BPD stands for borderline personality disorder and not bipolar disorder. Then there was my ex-girlfriend who jokingly said that the people from her codependent meetings, were always trying to get away from people like us. Another friend noted that the diagnosis made sense, as I indeed had charisma in groups. But for the most part, my borderline diagnosis didn't seem to matter to them at all, which I found both validating and invalidating. Because while I am more than a diagnosis, it still greatly impacts my life. Overall, despite a few sticky and perhaps imperfect responses, my friends did embrace me, even with this diagnosis. But I was having a really hard time with it. There was a lot of self-judgment and shame around having the disorder. This was not something that I would dare to speak aloud with other people. How was I to know whether that psychiatrist was right? Was I a psychopath? Would I ever be able to love anyone? Would anyone ever be able to love me? And there are grains of truth to the challenges around BPD, which I was seeing for myself firsthand. It's a difficult disorder to have and sometimes to treat. By the time I entered treatment, dialectical behavior therapy, my therapist was one of the sole people remaining in my life. Most other people had been alienated by my symptoms. Over the course of 3 years with my current therapist, God bless her, I had threatened to commit suicide, had drastic responses to her going on vacation, declared my love for her after 2 sessions, completely overstepped her limits in regard to contact between sessions, hung up the phone on her face multiple times, sent angry emails to the treatment team, and the list goes on, quite frankly. That's the thing, is that I don't have to listen to the outside world to know that borderline personality disorder can be difficult. And while I was incredibly unwell when I did those things, I have to learn how to integrate them into my view of myself. How do I see my behaviors in a larger context? Today, there's been a lot of talk discussing advocacy, advocating with others, family, friends, at the workplace, with insurance companies, in politics, in art, with mental health professionals. And that is needed and very important. And dialectically, After seeing how the Amber Heard trial and her diagnosis of BPD shook the BPD community, I became even more convinced that the first place that we need to advocate is within ourselves, internal stigma. Because how the world sees us and how other people treat us will never fully be in our control. We may be able to influence and educate and move the needle forward, but people with BPD cannot and should not have to wait on the world to accept us before we learn to accept ourselves. We don't need the world's permission to view ourselves with kindness, compassion, and understanding. And yes, there are a number of factors that can make us vulnerable to what the outside world thinks, from challenges with identity to a fear of abandonment to a need for validation to chronic feelings of shame and worthlessness. And those are valid experiences. At the beginning of my journey, I often questioned, why do I have to be like this? Why can't I just be normal? What would my life be like without BPD? Why can't I be like everybody else? Even the other members of my DBT group seemed to be doing substantially better than I was. What was wrong with me? If there was a relationship issue, it had to be my fault. I probably did something wrong. And so the outside world didn't need to invalidate me because I invalidated myself. The most critical voice in the room had become my own. We know how we feel about ourselves when our head hits the pillow at night. We know what we've accomplished that day and whether we're proud of ourselves or not. We know the ways that our disorder may have impacted our behavior for better or worse. And so the first point of contact must be how we see ourselves when we are by ourselves. To replace that inner critic with compassion. To substitute self-judgment for understanding and education. To switch the perspective from stigma to one of writing our own empowering narratives. These are my cries to action. Rather than living in isolation, here we are today in a community doing just those things. Today's conference is a joyful, exciting, and meaningful moment of peers with lived experiences of BPD leading the way. From my experience, community has been the single most effective antidote to dissolve internalized stigma. Because someone on the internet may say BPD isn't treatable. They're a hopeless group. But I know people who have gone into remission, recovery. I know people with BPD living full and meaningful lives. People may say that we're attention seeking and manipulative, but I know that some of the kindest and most thoughtful and compassionate people that I have ever met are from the BPD community. No one can take away that firsthand experience with their ignorance. Today, you have heard stories that no one can ever take away from you. Stories of hope, tenacity, pain, courage, connection, meaning, and overcoming. You are now part of this tribe. No internet troll is more important than that. This past December, I became a volunteer with Emotions Matter and began facilitating their BPD peer support groups. Watching how these groups run themselves and seeing how people show up for one another has made me so proud to be part of this community. In response to pain or suffering of any kind, group members are overwhelmingly empathetic, kind, supportive, encouraging, and validating toward one another. If you all are representative of what it's like to be a person living with BPD, then I am proud to be part of this community. Thank you so much for letting me share today.
Thank you, Alyssa. That just blew so beautifully. Thank you. Thank you for everything you do for us here at Emotions Matter. We really appreciate you, Alyssa. I'm going to go ahead and introduce our next panelist, Penelope. Penelope Gay has been a peer facilitator for Emotions Matter for the past 3 years. She lives in California with her partner, where the stray cats let the squirrels run wild. Penelope, the floor is yours.
Thank you. Just want to say, Alyssa, we do not need the world's permission to view ourselves with kindness. Thank you. I'm just going to take a moment and take a breath. There are how many of us here? 101 people. I know I can't see you, but I feel you. And it means so much to have us all gathered here to talk about stigma. This is not something I imagined would ever be possible when I was diagnosed in 2002. To be here with 101 people like this, proud, open about who we are, centered on lived experience. Paula and the other founders of Emotions Matter, thank you. I'm going to read you a piece I wrote about stigma. But first, a note. Emotions Matter has a beautiful philosophy. They don't tell people what to do. In this space, we speak from our own experience and do not dictate to others. What I'm about to say is framed as a set of instructions. These are my recommendations, and they do not represent everyone's experience with BPD. This is my way of showing you all how I deal with stigma. It's a letter I wrote to myself. These words have become my own personal anthem, and this approach may or may not work for you. That said, here goes. What's a nice girl like you doing with a personality disorder like that? The Lady's Guide to Facing Stigma with Grace, Panache, and Aplomb. First, remember, you are not the problem. Challenging stigma means looking in the mirror each day and saying, I am not the problem. You have a problem, and that problem is simple. You have intense emotions and live in a world not built for those who feel intensely. You will pay the price for this mismatch between self and society. But remember, this is not your fault. I want everyone who's been diagnosed with borderline personality disorder, if it feels right and true for you, take a moment and write in the chat, I am not the problem. Because we are not the problem. And now, some do's and don'ts for facing stigma. Don't write a master's thesis trying to statistically disprove that borderline personality disorder exists. Don't argue in front of a committee that BPD was made up by a bunch of sexist psychiatrists with hero complexes who are into BPD because it reminds them of the good old days of hysteria when women in corsets entertained and titillated psychiatrists while they were tamed. You may be very right about this. Your anger may feel powerful enough to take down an entire discourse. But you cannot do this alone. You cannot fight a discourse while you are still too ashamed to say out loud, I have BPD. You cannot create a new world when you believe you will only deserve compassion when you have learned to pass for neurotypical. Don't spend 11 years in denial. Don't memorize the borderline personality disorder symptoms and ferret them out of any description of what troubles you. Don't hide your borderline parts, then talk only about depression and anxiety to therapists. No one can help you heal if you are not real about all of it. Do remind the Psi complex that good intentions are not enough. I have spent hundreds of hours researching the discourse on BPD, thinking about stigma. I work with Emotions Matter to actively challenge it, and it still impacts me. Last year, I realized I was keeping something from my therapist because I'd labeled my emotional response pattern as borderline, and I felt too ashamed to talk about it. Stigma doesn't disappear because I know it's hurtful. It requires acknowledgement and action. Think of surgeons scrubbing up before surgery. They don't skip scrubbing up because they live in a clean house and drove to work in their clean car and they were alone in the elevator, so they're good. They're going to skip cleaning up today. It's accepted that bacteria are everywhere, and Everyone in the OR, no matter how clean their house is, needs to take precautions not to infect patients when their skin is open. Think of stigma like that. It is in the air. Treatment providers are going to run into it, in others, in patients, in themselves. People in crisis can be as vulnerable to stigma as someone opened up for surgery. Ask your providers, what are you going to do to deal with the subtle ways stigma might influence you? What is going to be your metaphorical way of scrubbing up before you see me? Don't let the bastards get you down. So what if a psychiatrist wrote a book called The Siren's Dance, My Marriage to a Borderline, a Case Study? So what if a revered psychiatric expert on BPD endorsed the book, writing, I have hopes that this book will find a place within the training of mental health clinicians. This book can titillate even as it teaches. Maybe those psychiatrists have compromised abilities to recognize the needs and feelings of others. Do watch Crazy Ex-Girlfriend. Notice how the character with borderline frees all the other characters, especially the men, to sing and celebrate all of their emotions. Don't turn bitter. Bitterness can feel like comfort, like a ragged sweater that keeps you warm even as your neck itches from the coarse wool. When you have BPD, there is plenty to be bitter about. There are so many ways to be a person in this world, and being stigmatized stunts our life force. When you try to get care again and again, and people slam doors in your face or blame and humiliate you, bitterness will sit down at your kitchen table and make you a promise. Take on my way of seeing things, she will say, and I will make this pain go away. Let the bitterness sit there, but do not adopt her worldview. She is funny and wry, and she will numb the pain, but you will be left with a perpetual ache. Unravel bitterness, because what is underneath is soft and vibrant. That part of you needs nourishment. Comfort the raw, tender self underneath the bitterness. Feed it warm soup and soft bread. Buy it flowers and soft sheets. Whisper, I love you just how you are in this moment. Do write a lot. Write an essay called How to Use Your Personality Disorder for Fun and Profit. And write the hard stuff too, the things that still burn, like a poem for the children you did not have, a poem about how homophobia and stigma tricked you into believing you would be a bad mother. 20 years later, this still guts you. How could you have trusted them more than your own heart? Do recover the damages. My neurodiverse, queer, dysregulating, borderline brain did not take anything from me. Our culture took my humanity. Sexism took it. Ableism took it. Saneism took it. The psi complex took it. I am recovering the self that was shamed into hiding. I am recovering myself. I used to cover in respectability. I used to grind my molars while I tried to pass for normal. I recover in flamboyant emotional expression, glitter, torn jeans, lipstick. My emotions are the texture of my life, not shameful secrets to shove down. Let someone guess I am not NT. Recover yourself in laughter, in connection, in art, in joy, in self expression. As for the psi complex, write them emails, make memes that call them out, post about them on social media, write, speak, write, speak. Refuse to be quiet until they change. Do not give up. Maybe you are better, have a respectable job in middle management. Not bad for a former career patient. Maybe you have changed so much in the past 6 years. The you from the past would not recognize the you who moves through this world without secret, fresh cuts to hide. But it is not enough. Even if you crush deliverables, manage clients and your team like a rock star, praise for fitting in is not enough. Sustain your hungry, compassionate warrior soul. Wake up so early it hurts. Keep striving for the life that feeds you. Dance your heart out each morning. Show up sweaty, unprofessional on Zoom, but show up whole. Thank you.
Wow, I'm crying. I don't know how I can continue doing this. Honestly, that was unbelievable. You have to go back and read the chat. So many people related with that, Penelope. It was really, really beautiful. Thank you so much. We have our third panelist, Sarah Masland. We're going to hear from her just in a moment. And when Sarah's done, we will have time for Q&A. So like I mentioned earlier, we have the Q&A tab at the top, at the right side at the top, and you can go ahead and put in your questions, and we'll go ahead and read it after Sarah's done, and all the panelists will be able to chime in and answer the questions. So I'm going to introduce Sarah. Sarah Masland is a clinical psychologist and an assistant professor at Pomona College in Claremont, California. Her research focuses on BPD stigma and good psychiatric management for BPD. Sarah, go ahead.
Thank you for the introduction. I am shaking. Alyssa, Penelope, your voices are beautiful. Thank you for sharing. I think that what I'm about to share will certainly pale in comparison. And I think that just highlights what is so beautiful about Emotions Matter, centering the voices of people with lived experience. Because, I don't have BPD, but I'm still shaking from what you just shared, and I'm taking things away from it. So thank you. So I'm going to share from a slightly different perspective as someone who is part of the Psi complex, as Penelope termed it, and someone who has probably in some ways unknowingly participated in things that cause problems for others. And I want to recognize that. And it's something that motivates me to do better. So I actually have slides that I'm going to share because I organize my life through slides. So I'll share my screen here. And just someone please chime in if you aren't able to see the slides. So I'm going to talk about my experiences with stigma first, and then I'll talk a little bit about how interest in stigma has increased in recent years. And then I'll talk about some barriers and solutions that I see in clinical spaces and in research spaces as well. These are the two places that I operate mostly. And then I'll also talk about some ideas for action, which are recommendations. So in terms of my experiences with stigma, these are some of the places where I have completed my clinical training. And in these places, the BPD stigma that I've encountered has been both subtle and overt. So in terms of an example of a subtle stigma, is that as an undergraduate, I learned nothing about BPD, despite taking all of the clinical psychology courses available in college. That kind of erasure creates a serious problem. Then when I worked as a research assistant before graduate school, I met postdoctoral fellows who were extremely influential to me and who told me that BPD was scary and untreatable. Mind you that at this point, I still didn't really even know what BPD was. And this certainly didn't motivate me. Oh no. Sorry, I'm gonna restart the share. My slides just disappeared for some reason. Okay. So, and that certainly didn't motivate me to want to learn more, what I learned from the postdoctoral fellows. In graduate school, there was little curriculum, again, devoted to BPD, but I at least had an advisor who understands BPD and takes a decidedly compassionate approach to understanding the disorder. My very first clinical training brought me face to face with significant overt stigma, which said that BPD was not a valid disorder and that in all cases it's caused by significant abuse or that people with BPD are difficult. These are things that I know you have heard. I first started to learn about what BPD truly is because I was interested in self-harm and decided to pursue clinical training at McLean Hospital. It was there that I learned a great deal about BPD from people who truly care about the people most affected by the disorder. But even among these folks who care about BPD, I noticed subtle language choices and framings that concerned me. Even the people who want to do well sometimes do harm, even if unintentional. Overall, the two main ways that I've interacted with stigma about BPD are first, seeing how it directly affects people and presents a barrier to recovery, both through self-stigma, but also through the way that it pervades clinical spaces and makes it more difficult to access appropriate treatment. And second, through what is called courtesy stigma. And I want to emphasize that the experience of courtesy stigma is wrapped up with privilege, because this is the stigma that people experience when they do not themselves have the disorder, but interact with or are associated with people with the disorder in a way that causes other folks to question them. Most times when I tell folks that I study personality disorders, I get questioning glances at least, or outright hostility in some cases. They assume that research is me search, and that I too must have BPD. And to that I say, what if I do? I'm not going to answer that question if you're asking me in a way that's being skeptical. The research is then delegitimized and I'm viewed with suspicion. Again, this is nothing compared to the experience of folks with BPD, but it's important to highlight because it likely contributes to there being fewer folks researching personality disorders relative to other psychopathology. This is a barrier to people entering this space as clinicians who want to do well. I'm not sure why I think I was maybe less affected by the stigma I encountered than some other mental health clinicians. I like to think it's because I'm naturally pretty skeptical and don't like to be told what to do or think. That's a benefit of low agreeableness, perhaps. And folks with BPD often have similar orientations. So perhaps it's no coincidence that I like working with them so much. I think a big part of it is just having contact with lots of people with BPD who've provided excellent examples of how the stigma is just so wrong. So my interest in stigma grew out of these clinical experiences and seeing how I might sometimes be part of this system that is meant to help people, but that often does harm. And I want to highlight that the interest in stigma, mine has grown in the previous years, but interest in stigma has also grown nationally and more broadly. This is the Google Books Ngram Viewer, which is this neat tool which basically tells you how often certain words are used in books across time. And there's been a significant increase in interest in both borderline personality and in stigma in past decades. I know that the axes here are a little hard to interpret, but this suggests that people are using these words more in books, and the interest is increasing. Note that this is also only in books, and the increase would likely be much sharper if we considered other forms of media.
Sarah, I'm just going to interrupt in case you're trying to share slides. I'm not sure if you are or not, but we don't see any.
Okay.
But if you need any help, let me know.
I think it messed up once and then. Are they there now?
It's not in full screen. Perfect.
Okay.
Go ahead.
So this is the chart that I was showing before with the Google Ngram. You can see the increase in interest in borderline personality and stigma over time. This is also a chart showing the number of publications in peer-reviewed journals that have related to stigma from the time period of 2004 to 2014. The interest in stigma is definitely growing. The American Psychological Association recently devoted an entire journal, Stigma and Health, to the study of stigma. So this is something that people are increasingly interested in and aware of the downfalls of stigma and working to deconstruct it. So I'm going to shift gears a little bit to talk about some things that I've become interested in as ways to deconstruct stigma in clinical spaces and in research spaces. So first, in clinical spaces, we know that one of the things that actually really perpetuates stigma is that clinicians who presumably have been trained to treat folks with various forms of psychopathology often actually don't know very much about borderline personality disorder. There was a paper recently that examined the supply of mental health professionals who are trained in specialized treatments for BPD, for example, DBT, across 22 countries. And what they found is that the ratio of treatment-seeking people with BPD to these mental health professionals with this specialized training was nearly 50 to 1 in Norway. What that means is that there's 50 people with BPD seeking treatment to every one clinician who has had specialized training for treating BPD. 50 to 1. But look at this in Mexico, nearly 150,000 people with BPD to each one of those clinicians. And in the United States, nearly 6,000 people with BPD to each one of those clinicians. And so this is a serious problem for treatment access, but this is also a very serious problem for how stigma might be perpetuated. Because we know from other research, and some of this is research that I've done, that when we train clinicians about BPD, we actually give them psychoeducation. We lay out the facts for them. We destigmatize, we demystify. We tell them about the etiology of BPD. We tell them the true things that we know from research, that does reduce negative attitudes towards patients. It makes clinicians more likely to give the diagnosis. It makes them more likely to accept people with BPD into their caseload. These are 3 studies that have looked at this. These are just short trainings that train clinicians about BPD and that improve their attitudes about BPD. So we have 2 things happening. We have a shortage of people who know about BPD, and we know that if they knew more about BPD, they'd be less stigmatizing. I study good psychiatric management. I just want to highlight this because I think that it's a hopeful note. Good psychiatric management is one of these treatments that's been studied. When you learn about GPM as a clinician, it reduces your stigmatizing attitudes. And the online training for GPM, nearly 10,000 people have taken this training just recently across 96 different countries. We've also done at least 28 in-person trainings for free across many countries, including Brazil, Sweden, the Dominican Republic, France, and Canada. So we're getting this information out. It might be a little slow going, but when we think about easily disseminated trainings like this, it has the likelihood to make a really big impact. So when clinicians have training about BPD, they have more positive attitudes about BPD. They feel more competent and prepared, and they're more likely to provide appropriate care. I want to recognize that what we really need to do as a field now is start disseminating training to clinicians who are in training programs. So, it should have been part of my curriculum when I was learning to be a clinical psychologist. It should be part of the medical school curriculum. There are folks working on this. I worked to get a training initiative in place for residents in a psychiatry training program. And there are folks working on this in other medical school settings as well. So this is something that is kind of on the horizon, but also the momentum is starting to build. So I don't want to unnecessarily blame just clinicians, right? Stigma is not confined to clinical spaces. Research both reflects and perpetuates stigmatizing ideas, language, and practices. And actually, many clinicians are also researchers. It's not enough for us to design specific interventions for clinicians when they may be reading academic texts that perpetuate stigma. And also, people living with BPD may be coming across articles that are supposed to be research-based about BPD, but that have really stigmatizing ideas baked into the language or the study design. Here, intersectional issues are really important as well, because most research on BPD has focused on women who are white, cisgender, and heterosexual. So what this might do is actually perpetuate stigma that's specific to certain types of minoritized identities. So I came together with a group of folks actually on Twitter when we identified an article that was really concerning in terms of how it was presenting stigmatizing ideas about BPD. Many of us wrote letters to the editor to try to get this article changed. The authors of the article kind of pushed back and didn't seem very receptive to feedback on how they were perpetuating stigma. And so we came together and said, let's actually write something about this and get this put in a place where many researchers will read it. So this is a paper that's currently in press in a journal called Perspectives on Psychological Science, which is a high impact journal that many researchers read across subdisciplines of psychology and psychiatry. And what we did is we looked at outlining the stigma that there is about BPD within research context, and we provided recommendations for researchers. So these recommendations are just selected recommendations. I'm not going to go through all of them, certainly in the interest of time, but I thought that these might be some that are particularly interesting to folks attending the conference. So one of them is to seek collaboration with people who have expertise in BPD and people with lived experience. We need to follow the model of Emotions Matter and center the lived experience in our research process. People with lived experience should be paid to consult on designing research projects, on thinking about how we talk about research findings in the literature, to decide what we study, what's important to the community, and also to help us determine editorial guidelines. We also need to involve people who have been minoritized at all levels of the process. So we need to consider intersectional identities here. We also provided guidelines for language and how to frame questions in ways that won't do harm. And we also encourage everyone to act when you see problems. We encourage researchers and clinicians and anyone who's interacting with these research articles to write to editors to say, hey, this is a problem that we see in this article. How can we reframe this so that the science you're doing, which I think you intend to be doing good, isn't causing harm? I want to read you one of the passages that we have at the end of the article. We write, many of the people with BPD in our lives or with whom we have worked professionally are among the most caring, bright, fun, and creative people we know. As is true for people with any psychological disorder, they deserve research dedicated to the betterment of their lives and reduction of suffering. Although psychological science has made important advances in understanding and treating BPD, the field must come to terms with a long-standing history of stigmatizing language, study framing, and research practices. Clinical psychology and psychiatry should take the lead in correcting this history, given their proximity to BPD, yet other subdisciplines also play a critical role. This is a call to action for us to remember the people behind the numbers. So that's a call to action for the research community. Some other ideas for action quickly, just in the last minute or so here. These are based on what we know causes reductions in stigma. So joining peer support groups and communities, I think Alyssa and Penelope have spoken to this. Alyssa talked about how she has these great examples that combat stigma. That's what you get from peer support groups and communities. When you feel safe, share your story. I think what Penelope and Alyssa just did was so brave and destigmatizing. And we know that contact or knowing people with a disorder is the #1 way that stigma gets reduced. That's been shown in decades of stigma research. Here's some great examples of contact. I just pulled a Twitter handle that I follow where someone talks about their experience with BPD in a really powerful way. Kellyanne, I think, is in this session, writes about her experience on the Mighty. These are really powerful ways to share your story. Emotions Matter also has some resources for this. So these are links that you can use. For example, the organization will be launching a Google form to gather information about insurance denials, to inform advocacy efforts as we push for insurance coverage. You can also use researchgate.net to ask authors for articles and start conversations if you want to be part of reducing stigma in the research community. This is also a great way also to get some psychoeducation, because learning about BPD through the research is essential for reducing self-stigma as well. I want you to also know that local community actions are often the most powerful. We know that from the stigma research. You can write to editors and authors when you have concerns, as I just said. You can also participate in research. And Emotions Matter has put together a list of potential research projects that have been screened in some way that you might want to participate in if you feel safe doing that. I also encourage you to take a look at your state laws and contact your representatives. One thing that I'm doing right now is I've started to look at California Penal Code. There's a code actually for prison diversion programs. This is where people get diverted to care rather than to prison for nonviolent crimes. And there's actually 3 exceptions to that diversion program. And this is pretty inflammatory and concerning. They are for antisocial personality disorder, borderline personality disorder, or pedophilia. And including BPD on that list is horribly stigmatizing and based on stigmatized beliefs. So I'm currently in the first stages of approaching representatives and actually thinking about a plan to address changing the California Penal Code, because I live in California. So in summary, we know stigma is problematic across contexts, but I want you to know that significant efforts are underway to make changes. We're training clinicians, we're rethinking research processes, we're combating insurance discrimination and increasing public knowledge. The public is increasingly aware of and interested in deconstructing stigma, and you can be part of these efforts too. Research shows that local actions are often the most effective, and even if you're doing something that changes the life of just a single person, I would say that that is a seriously meaningful impact. That person could be you, or it could be someone you care about, or it could be someone that you've never met. I hope that you feel inspired from this day of talks to take some small action. Thank you.
Wow. Thank you so much, Dr. Sarah Maslin. That was incredibly important and just mind-blowing. I've never heard most of what you had said, and I'm just so glad that you're here, part of this panel. And we've heard a lot of different perspectives on this, and we do have some questions in the Q&A. You all can go ahead and put your questions in there. There's also some really great comments. So I encourage everybody to read them. I mean, people have said such beautiful things, and people are relating to everything. So that's really, really fantastic. The first question is for Penelope. This was written previously right after you had spoken. Can we get Penelope's stunning poem? And I think somebody in the chat said, you should publish it.
Yeah, I have plans to send it out. So I'm really good about writing stuff, but I'm not as good about publishing it, but that one is going to go out for sure. So thank you.
Awesome. The next question is for Dr. Sarah Maslin. As someone living with BPD who often struggles with the effects of stigma, specifically in the workplace, are you, as a psychologist, the primary resource involved in the process of discussing seeking out disability support? If so, what is your specific role in that process? It is so difficult to know which of your doctors or providers is the best advocate to help you deal with stigma, especially if it affects you and your ability to function daily in the workplace.
Mm-hmm. So I think that different clinicians are going to take different approaches to this. I would say that if I'm the primary therapist for someone, that I would absolutely help them in that capacity. Some other therapists might say that feels like more of like a kind of what they call case management role. But if you don't have someone who's a case manager, then your clinician is the person who should be helping you navigate that for sure. I hope I answered the question. Please let me know if I didn't.
Thank you so much. The next question we have, is there something we can do to protect ourselves from stigma on social media? I want to start sharing my experiences with BPD on social media, but I'm worried putting it out there will skew how a potential employer sees me. Anybody?
I can share briefly on that. I started an anonymous Instagram account, DBT Exchange, and so that's how I've been able to put out content. I haven't really put things out under my personal name per se, because of concerns with searching for a job and other issues that arise. But I do put my face and my image and my name to a lot of the content. And I would say that on that account, I would say for the most part, all of the content is supportive and encouraging. There's the very offhand remark that isn't. And I haven't had any issues. Very thankfully, there's been a growing supportive community online. But there is always a risk, I guess, to some regard. And I think that's a valid concern.
Thank you. Just going back to the previous question, Sarah, the person who asked it said, thank you, perfect. So you answered the question. Okay. So that's just wanted to tell you that. We have another question. In Europe, BPD is known as emotional unstable personality disorder. Would a change in the terms BPD or EUPD do you think there might be less stigma around it?
I can answer from like a research perspective. This is actually a qualitative study that I'm just about to start. I'm seeking some consultation from folks with lived experience on the qualitative study to get a sense from the community about what they want BPD to be called. But I'm not sure that changing the name is going to solve all of the stigma, because people will still know what that name is, right? And I think that actually the ICD is moving away from that term, emotionally unstable personality disorder. I think that part of the thing that might be the trickiest in the label is the words personality disorder. Just given, and I'm just speaking actually from some data that I have. So I'm not sure that changing the name is going to solve all of the problems. I think it's a step forward. I don't know what the name should be at this point. I would love to hear what you all think, Penelope and Alyssa.
I'm conflicted. I know Marsha Linehan, who created DBT, wanted it to be called emotional dysregulation disorder. And I heard that and thought like, oh, that's just a description of what's happening, and it's less stigmatizing. Those words, personality disorder, are just deeply upsetting. But through the reclaiming I've been through, there's something about the word borderline that I just find so, it resonates. And I don't know if they're like, the problem I think is so much bigger. Like it centers, it happens within borderline personality disorder. It's so easy to see what is going on within this entire system. So I think the problem's bigger. I don't know. What do you think, Alyssa?
Yeah, I agree with you completely, Penelope, that the issue is larger. I almost feel like if we change the name, which is fine, I don't particularly have strong feelings about it, but I feel like it'll end up becoming like the artist formerly known as Prince. You know what I mean? People would just be like the condition formerly known as BPD, you know? And so I think it's just changing the dialogue around the actual disorder.
Any other thoughts? All right. Thank you so much, guys. I can't even keep up with the chat because everybody is so thankful and relating to everything you guys are saying. So thank you again. You guys are amazing. There was a question that got deleted, but I do want to address it. It was to you, Alyssa, about what support groups you lead. So go ahead and tell everybody.
Well, since you asked, I was trying to answer it and I think I accidentally deleted it. I'm sorry. But it's actually Emotions Matter. They facilitate, and I help to facilitate. So does Penelope. Penelope also facilitates. We've done it together, BPD Peer Support Group. On Emotions Matter website, you can go ahead and find the support groups that are peer-led. And yeah. Maybe I can even put that in the chat or something of that nature. So I'll put that in the chat.
Awesome. I see here another comment. It's not really a question, but it is a comment. So much pain. Everywhere I go, I hear shaming comments, including from many clinicians who talk very publicly. I don't even know how to avoid and protect myself. Comments on that? Okay. We do have a few more minutes before we wrap up.
I just need a second to think about it.
Yeah.
Okay, yeah. Go ahead.
Yeah. Can you read it again? Don't know how to avoid or protect myself?
I don't even know how to avoid and protect myself. I guess avoid the stigma and protect myself from the stigma, I'm guessing.
I think there's like, you have to work really hard. Like I live in Northern California, which is supposed to be this really accepting place. And when I moved here, it was really hard to find a psychiatrist that would treat someone with borderline in the way that I was like, what? This is San Francisco? And you're like, no. So there's the researching and like finding people. And I do ask, when I was on that search for a psychiatrist, I asked people, what were you taught in school? Because that's kind of a non-threatening way to ask someone about and find out where they land with stigma. And that answer would tell me a lot about if I could trust that person. And then it's a constant, like Alyssa talked about, like it's a constant dealing with within yourself because it gets inside of us. There's a famous quote from a sociologist from the 1960s named Irving Goffman, and he went into an asylum to see what it was like. And he wrote about how a psychiatric patient coming out is going to judge every emotion that they have. Like, and I definitely, that still really resonates with me. So part of that, like, protection is the care, like caring for yourself, because it's so painful. So like, I don't think I can build a shield from it, but I can find a way to care for myself in it and connect to people around it who understand, who share that experience. I think it's a really good question.
Yeah, and I can add. Mm-hmm. I can add something too. I don't want to over simplify the matter, because I struggled tremendously with internal stigma when I was first diagnosed, particularly after the psychiatrist had made the comment to me about, being a psychopath. And, and so that was very challenging, and I really struggled with it, but I was thinking the other day, if someone were to say to me, I really hate your pink hair, I'd be like, okay, like, that's all right. You can hate my pink hair. That's fine. And I think being part of a community of people with lived experience of BPD, like, I know how wonderful we all can be. I know how wonderful you all are. And so if someone has something negative to say about BPD, I don't take it to heart. I don't take it that seriously. I really know it's not true, just like I don't have pink hair, So if that kind of, imagery or metaphor helps, then I hope that's helpful.
I love that. Absolutely love that. It's not true what they're saying. So it's good to be able to say, it's not true. It's not going to affect me. I'm not going to let it bother me. That's excellent, Alyssa. Thank you. We don't have any more questions in the Q&A. If anybody has any more comments, panelists, otherwise I'll wrap up.
I just want to take a moment with that penal code in California.
Yeah. It's horrible, right? It's actually something that Paula pointed out to me. And, this is early stages, but I want to do something about it. I've started to, talk to an attorney about it, and we've got to get that changed.
Yeah, it's like, I think I've like heard everything and seen it all, and then I saw that and was just like, come on.
Yeah, I hesitated to present it as an example because I didn't want it to be like kind of a downer, but I think that the message is that, like, we all have a role to play, because like these things, they're everywhere. It's pervasive, and we all have to kind of be looking for it to ferret it all out, essentially. So I'd encourage folks to look at their state laws. Like, there's folks in here from, I saw Oklahoma, Colorado, like, look what's on the books.
Yeah, I'm glad you did, because I live in California and I have a big problem with that.
Yeah.
Thank you so much, guys. I'm going to wrap it up. We have 2 minutes left. So on behalf of Emotions Matter, I want to thank the panelists for sharing and for this insightful discussion. Thank you to the attendees for all the questions and the comments. I'm sorry if we didn't get to all your questions. There is one left, but I really have to wrap this up. Just so you know, there are resources which are downloadable links related to this topic. If you click on the details tab, you will see those downloadable links. I'm just going to share my screen one last time for another announcement. Very exciting, big event coming up for Emotions Matter. Our first in-person event is we're having the Walk for BPD in New York City. And this year we're doing it hybrid. So you can walk virtually. You can walk in your city. You can watch our live stream. It's going to be super exciting. And it's a really important fundraiser for us. We offer conferences like this and programs for free to our members. And we really need your help to help those people. So if you're enjoying what you're seeing today, please go to the donate tab in the lobby and make a donation to Emotions Matter. And we really appreciate your generosity. And you can also go to our website to sign up for the walk. We have one more very exciting plenary session. We have a break coming up right now, but in 15 minutes, there's going to be the last plenary session. I can't wait to see you all there. Thank you all so much.